each one separately. In terms of prevention, 40% of cancers are linked to lifestyle, and the top one being smoking. There's a lot of smokers. The smoking percentages are significantly higher in our deprived populations, and tackling that one lifestyle factor, smoking, would make a lot of difference, and that is something that we do need to be mindful of. Early detection and prevention of these risk factors is therefore helpful. So whether it's obesity, whether it's lack of exercise, each one of them contribute to the outcomes, to early diagnosis, to any diagnosis, and to the outcomes of patients with cancer. So stopping these at any stage is helpful. So this just shows the smoking prevalence and a comparison between the least deprived and the most deprived areas. And this just plots the Berkshire West GP practices. And as you can see, the most deprived have significantly higher prevalence of smoking. Obesity. So children and adults from more deprived populations are more likely to be obese. Now, you might think, well, it's poverty, how are they obese? However, we do know that there's a lot of advertising of fast foods, junk foods. Junk food is cheaper, takes less time to prepare, and if you think about families on low income who need to fill their tummies, what is easier is getting some high energy stuff which makes them feel full. And sometimes you get 2-for-1s and all these kind of prepackaged foods, so it makes their life easier and they don't feel hungry. Healthy foods are great, but according to the Marmot Review, if the lowest 10% income families ate healthily, 74% of their disposable income would go in food. And if you think about what other challenges they have with paying their rent and electricity and other things, it's difficult. Fuel poverty is also a big thing, not just for heating, but also appliance poverty. People are switching off their freezers, they're not using their cookers because the bills are very high. So I think when we give advice in our practices to people about eating healthy, perhaps think about switching foods rather than you must eat fruit and veg, because can they afford to get fruit and veg? Whereas if they can sort of replace a few things, it might just make it easier for them. And again, that starts the child obesity is going up, and then that tracks and it goes on to adult obesity. So you can see the numbers just going up. Coming to screening, so screening uptake is lower in more deprived populations, and we need to think why. And this is again a map of Berkshire West, and if you see the practices in the middle, or the areas in the middle that do less than 70% are areas of deprivation. And again, we need to think about, well, why are these people not coming for screening? Is it economic that if our clinics are being run in working hours, can they afford to give up time from their job? Is it a mother who's a carer, looking after 2 young children, can she come for screening? Have they got the bus fare? Have they got someone to look after their children? There are so many factors that come into it. So if we think about it a bit more holistically from the patient perspective, perhaps it might help us to sort of think of different ways of working, maybe having some clinics on a Saturday where they can have their partner look after their children, or offering them sort of, can they self-book so they can pick a time which is easier for them. So it's multifactorial, and also talking to patients when they come in, making every contact count, because if they come in and we see that little blurb at the bottom saying cervical smear overdue, maybe having that conversation to understand why they don't want to come forward. Is it they're embarrassed because it's an intimate examination or intimate part of their body? Is it that they don't understand? Is there any stigma? Because some people think, well, if I get cervical cancer, people will say I'm promiscuous, and therefore is it commenting on my sexual history? So it's again, just trying to understand what the issues are. And finally, also language, because if English is not your first language, do you even understand whether it's a cervical smear or bowel screening or breast cancer screening, what it means, why is it important, and how does it help us? So what can we do in general practice? Like I said, make every contact count if we can. We don't have to do a smear there and then, or make any other intervention, but we can at least remind people or try and understand why they can't. Similarly, there are prevention services that we could refer people to for weight management, for lifestyle services, for diet, and we should try and utilize all the local services that are available to them, or send them reminders or send them a text message with some contact details, which may be helpful. So coding is caring, and the reason we put it here is that it's not just deprivation, it's multifactorial. Often people living in deprivation also have other issues, so they may be from minority communities, they may not speak the language, so there are lots of issues going on at the same time, which may be contributing to this. So if we code them, so ethnicity coding is really helpful and important, and that's why in this year's LES we do put that on, because once we've coded ethnicity and we know about the deprivation or which wards people come from, it then makes it easier for us to understand, is this a cohort of people, is this a particular area, how best we can help them, how can our care whether it's our care coordinators or community link workers, how do we outreach into that community? And this is a little bit about population health management, and basically, like I said earlier, was about individual patients and MEG, but if we have a cohort of patients, how do we reach out? How do we know our population, know our data through our coding, through the ICB, understand what their needs are through our community workers, gather all that information. We can do that at practice level through our PPGs, at PCN level through our community connectors, and also our voluntary sector, is very supportive. And if we gather that information, then we understand our local population and how best we can support them, whether it's for prevention, whether it's for early diagnosis and getting them to come up, or for screening. And finally, just going to touch a little bit about neighborhood teams, and there was this philosophic vision where they talk about streamlining care. So bringing together primary care, community care, secondary care, voluntary sector to align as neighborhoods so that the care is more joined up and it is more holistic. And that is the vision for the future, for people to be able to take hold or control of their own health, but be supported by this entity around them, and use the resources more wisely. Patient feedback and engagement, I've talked about this, that all of this engagement at individual level and from outreach work, from our data at PPGs is helpful for us to think holistically. So health access to care, healthcare quality all vary, and cancer isn't any different. So we can perhaps look into our systems to see how we can improve things. I know we've talked about prevention, screening, and community engagement, but we could also do things in our practices like audit patients who have presented to the emergency department and see what happened before. Could we have picked this up earlier? Why did they present as an emergency? Were they not able to communicate? Were they not able to access us? What was the issue? And that is learning. So if we do like a significant event analysis of patients with cancer, we as practices would learn a lot more to understand how we can make our own improvements, and they may be different for each one of us in our practices. That's it. Okay, sorry.
You're in
That's one
slide.
more slide. Any questions at all? Thank you.
More of an observation, really. I was recently tasked to find the COPD leaflets in Arabic. That wouldn't be too much of an issue, surely. I could not find one. So thinking on what you're saying about languages, you know, I contacted different charities, I contacted the respiratory hospitals across London, you know, East London, South London, you think there'd just be loads of it. Northern England I went to, because I looked over, I went after Arabic populations, I thought their hospitals might have it. And in the end I had to give up because I couldn't find what I thought was a basic COPD is so common. I really wasn't expecting not to be able to find a leaflet. So, you know, picking on what you were saying about difficulties for people accessing healthcare due to language, is this something that perhaps we can do a bit more in terms of, you know, it's been on for years people talking about putting people in different languages.
And that's where the needs assessment comes in, because you know your population best, and what are their needs, and then come up, you know, talk about solutions. I have brought up leaflets before, but then there are so many languages and so many dialects that do people actually read, it then makes it quite complicated. So I think Google Translate is really helpful.
I think there is, on Macmillan, there are health needs assessment and everything is converted into 19 languages, if I'm not mistaken. But yeah, certainly it's in Macmillan website. You can but not COPD.
Yeah, hi. Thanks for that. Really good and a really nice summary. I think though, and I'm not expecting you to sort this out, but there's a really big problem between what the issues are that you're addressing and the actually commissioning of things. Like I'm the lead cancer nurse at the Royal Bath, and we're really struggling because we know that Nietzsche's project on Cancer Champions has been working in Berkshire for like 7 or 8 years, really delivering those things. It's talking about how to improve access to cancer care for people who don't speak English, who may be culturally estranged from where they are. That's really helpful. We've also got people's psychological needs that aren't really being addressed, and we've got a scoping report, and it seems like none of that can be commissioned, none of it. So we've got, all we can afford to do at Bob ICCD level is fund cancer treatments and cancer targets, and that's a real shame. There don't seem to be any money left at all, because Nietzsche's project is still running on a month-by-month basis for funding. The psychological report outcomes won't be funded. So it's really, I think if we're serious about doing this, and I think we are, because you're absolutely right, we have to think of a way of addressing that issue, or else it will just keep on coming up. We'll be talking about it in 10 years' time.
I agree.
We have part of the GP part of the project, which is doing a community health inequality work. We've got a big bit of funding from the ICB to do NHS health checks in Woking and Reading and West Barts in the most deprived areas. Like we're delivering 10,000 health checks. Right. This is the opportunity to link with Macmillan, because we're going to, RVA are working in sites in Reading, and there will be people there who GPs cannot contact. Because I've got a little bit of, I think the access is a massive issue. I do agree with that. I think we all know that to GP, people can't get to us. There's also some populations, the travelling community, who don't trust us. They're not going to go to the police, they're not going to come to the doctor. So we need to go to them, we need to change the model. We're doing it wrong for some communities. So I think this work is so important, and if we can get together, then we can have more voice and then get the funding sustainable, because our project's only 2 years, like yours. So we need to show the numbers to make it work. And
absolutely, I think we need to back it up with numbers to show that not just outcomes, but financially, we are doing better because we save so many people from accessing the really expensive therapies. But also shared learning, I think, is very important, because in Berkshire you've got an amazing example of the good work being done with cancer, for instance, sharing that with the other 2 areas. and in trying to implement it, even if at local level over there, the more momentum we gather, the better voice we have.
And the patient stories of
Yes.
having a cancer
Yeah.
patient is
Absolutely.
more powerful.
Absolutely, yes. Thank you very much.